Hello, my name is Casey Bryant, and I'm chest faculty visiting from Wake Forest University Health Sciences and School of Medicine in Winston-Salem, North Carolina. And together I worked with Dr. Sarkar, who's an interventional pulmonology intensivist extraordinaire. And we put together this teaching pilot on hyperangulated video laryngoscopy. It is built on the Enduvo virtual reality platform, and we hope you enjoy it. So the first thing we want to highlight is the differences between the blades. If I can direct your attention to this picture here, you'll see three different types of blades. On the bottom, you have two traditional direct laryngoscopy blades. On the very bottom, you have your straight Miller blade, which is designed to physically lift the epiglottis. Above that, you have your curved Mac blade. That is designed to sit in the vallecula and lift the epiglottis indirectly. If I can direct your attention to the anatomic model, you'll see the epiglottis here with the vallecula just above. And through patient positioning and direct laryngoscopy technique using those blades, the intubator will obtain a direct view, a direct line of sight to the vocal cords and the glottic opening to allow intubation of the patient, or at least that's the goal. You'll see on the top of the picture here this hyperangulated blade, and you can easily notice how acute that angle is. And that blade is actually designed to go around, if we can go back to the anatomic model, to go around the tissues of the upper airway, thereby providing an indirect view of the vocal cords and glottic opening to allow intubation of the patient without direct visualization of the vocal cords and glottic opening. And that in its core is the difference between these blades types and your approach to the patient. I would encourage you to pause the lesson and take some time and interact with the cut planes of the anatomic model, just kind of familiarizing yourself with some of the tools that are available to you in this virtual reality environment. You can make the model bigger, smaller, change your cut plane to look at different parts of the anatomy, and just kind of get used to some of the tools that are available to you in this environment. When you're ready, continue the lesson and we'll go on to the next portion. All right, for the second portion of this lesson, we're going to focus on the various different airway axes and how your approach to these axes changes depending on whether you're performing direct laryngoscopy or hyperangulated video laryngoscopy. So I'll direct your attention to these three pictures here. And these MRI images basically demonstrate the three different airway axes and how the alignment of these axes changes with different patient positions. I'm going to pull this picture over here so we can demonstrate the neutral position on our anatomic model. So you have your oral axis here. You have your laryngeal axis here. And then you have your pharyngeal axis here. And through patient positioning and direct laryngoscopy technique, you're trying to align these three axes as much as possible so that you can obtain a direct line of sight to the vocal cords and glottic opening and thereby intubate your patient. In direct laryngoscopy, for most folks, a sniffing position is recommended. And sniffing position involves flexion at the neck and extension of the head, and that better aligns your axes to facilitate direct visualization of your vocal cords so that you can intubate your patient. For obese patients, your approach may change a bit with ramping in order to align your sternal notch and your external auditory meatus. There is ongoing debate about the best intubating position, and that debate is outside the scope of this lesson. We're going to focus more on hyperangulated video laryngoscopy. And that can be performed in the neutral position. So I'm going to move these arrows out of the way. So in hyperangulated video laryngoscopy, the laryngoscope blade is designed to enter the oral cavity, go around the tongue to the base of the tongue, and then sit in the vallecula or lift the epiglottis in order to provide an indirect view of the vocal cords and glottic opening so that you can intubate your patient. This concludes this portion of the lesson. I would encourage you to pause the lesson, take some time to practice that maneuver of inserting the blade in and traversing behind the tongue posteriorly in order to obtain that view. You can also take some time to look at the various different MRI images and spend some time looking at the airway axes. When you're ready to continue, lesson 3 awaits. All right, for the third portion of the lesson, we're going to focus primarily on insertion of the hyperangulated video laryngoscopy blade and things that make this portion of the technique unique. And we're also going to focus on a simple maneuver that you can utilize to improve your view when performing hyperangulated video laryngoscopy. So if you'll join me to this side of the anatomic model. As we have reviewed previously, the hyperangulated video laryngoscopy blade is designed to go into the oral cavity, around the tongue, and then sit in the vallecula to provide an indirect view of the glottic opening. This blade is best paired with a rigid stylet, which you see an example of here. And you can see how this angle is very complementary to the hyperangulated blade. And here you see an example of the rigid stylet within an endotracheal tube. To insert the hyperangulated blade, you need to take the handle of the laryngoscope blade and direct it towards the patient's chest in order to orient the tip of the laryngoscope blade in a vertical fashion. So I want you to watch this video here, and that technique is going to be demonstrated. You can pause the lesson and watch it as many times as you'd like, and restart the lesson when you're ready to proceed. So once you insert the blade and then you watch it go behind the patient's tongue and the tip disappears behind the tongue, you would then direct your attention to the video screen. This video here is going to demonstrate what happens when the tip will follow along the posterior tongue and land in the vallecula and lift the epiglottis indirectly, allowing a view of the vocal cords. The blade will also be inserted further into the airway mannequin or patient, allowing direct lifting of the epiglottis to provide visualization of the vocal cords. Once you have inserted the blade and you've seen it go past the posterior tongue, there's a simple technique called rocking that will be demonstrated in this video here, where you take the handle and you rock back gently in order to improve your view of the glottic opening. This is different from the lifting motion that you do in direct laryngoscopy, so it's a simple rocking motion. Take a second to watch this video, and it's going to demonstrate that technique. You may pause the lesson and watch as many times as you'd like, and restart the lesson when you're ready to proceed. All right. While paying close attention to the patient and their mouth to make sure you're not causing any oral or dental trauma, you'd also want to direct your attention to your video screen. And this video here is going to demonstrate the change that will happen in your view, where you'll go from seeing just posterior pharyngeal structures to actually being able to visualize your vocal cords. That will help facilitate intubation. Feel free to pause the lesson, watch any of these videos again. You can also practice on the anatomic model with utilizing your hyperangulated blade and visualizing how it goes behind the posterior tongue. And when you're ready, you may push play and continue to the next lesson. All right, for this portion of the lesson, we're going to focus on insertion of the endotracheal tube that is loaded with a rigid stylet and the different aspects of this portion of the procedure that make it challenging. So if you'll join me at the head of the bed. So imagine that you've inserted the laryngoscope blade, you performed your rocking motion, you have a beautiful view of the vocal cords. You could then have an assistant pull the patient's right corner of their mouth outward to facilitate insertion of the endotracheal tube. You would then be handed the endotracheal tube, and you would insert the endotracheal tube at the right aspects of the patient's mouth, and then begin to follow the laryngoscope blade posteriorly behind the tongue. As the tip of the endotracheal tube disappears behind the tongue, you would want to direct your attention to the video screen. But first, I'd like to direct your attention to this video here, where insertion of the rigid stylet loaded endotracheal tube is going to be demonstrated on an airway mannequin. So take a second to watch that video. All right, so once you see the tip of the endotracheal tube pass behind the tongue, you would change your attention back to the video screen. And what you'll see in this video here is the endotracheal tube will come into view. And then there's a very important step that will happen, and that step involves stopping. So once the endotracheal tube passes just past the vocal cords, you're going to want to stop. And you're going to want to start backing out the stylet intermittently. You don't want to back it all the way out, because then you lose the form that the stylet provides to the endotracheal tube to allow it to overcome some of the acute angles. But you do not want to continue advancing the tube with that stylet in place, because one, it'll be very challenging to advance it any further because it's going to hang up on your anterior tracheal structures. But number two, you can cause some serious damage to the trachea itself. So it's very important to stop and intermittently back out your stylet. If I can direct your attention to this video here, that technique is going to be demonstrated. And you can have an assistant help you do this, or as the intubator, you can do it yourself. This video is going to demonstrate the intubator backing out the stylet intermittently while advancing the endotracheal tube further. As with other lessons, you can pause, watch all these videos as many times as you'd like. When you're ready to proceed, just restart the lesson. All right, in this fifth and final portion of our lesson, we're going to talk about a couple of troubleshooting techniques that you can utilize to hopefully help you successfully intubate your patients. So as many of you know, with hyperangulated video laryngoscopy, it can be quite frustrating because you will oftentimes obtain a fantastic view of the vocal cords, but then have a lot of trouble with actually getting the endotracheal tube to pass through the vocal cords. So hopefully these two techniques will help make life a little bit easier for you. The first technique is demonstrated in this video here, and you will see that there's a side-to-side motion utilized at the handle of the rigid stylet that is translated to the end of the endotracheal tube. So if you want to take a second to watch that video before directing your attention over to this video here. In this video, that side-to-side motion within the airway is demonstrated, and you can see that the endotracheal tube tip can be adjusted to the left or to the right or whichever direction in order to position it between the vocal cords for successful intubation. So take a second, watch those two videos, and when you're ready to proceed, you can restart the lesson. All right. So a second simple technique you can utilize is demonstrated in this video here. And that technique is simply called backing out. And it's exactly what it sounds like it is. So oftentimes you're too close to the airway, and that doesn't allow for enough anatomic real estate for successful passage of the endotracheal tube through the vocal cords. And by simply backing out a slight amount and then reobtaining your view, and then attempting to pass the endotracheal tube again, you can successfully intubate your patient. So take a second and watch that video as that technique is demonstrated. Again, when you're ready to restart the lesson, just push play. All right. So now for a couple of real life examples. So in this first example here, in my opinion, they're too close to the airway itself, and they would have made things a lot easier on themselves by simply backing out a slight amount. And you'll see that they bounce off of the arytenoids a couple of times and are deflected posteriorly before they are able to successfully pass the endotracheal tube. So take a second and watch that video and think about the things that you could do from a troubleshooting standpoint to um, make intubation easier. All right, and now I'd like to move on to a second real life example. And in this example, you'll see that the intubator actually goes down to the right aspect of the airway. And then with a simple leftward adjustment of the video laryngoscopy blade, the epiglottis pops into view and they seat themselves in the vallecula. Again, I think they're probably a little bit too close, and that makes passage of the endotracheal tube a little bit more challenging than it needs to be. And by simply backing out, they could have potentially made intubation in this patient's case a little bit easier. Additionally, they did find themselves a little bit oriented to the right of the patient's tongue and airway. And by trying to stay midline with the hyperangulated video laryngoscopy blade, they would have potentially seated themselves in the vallecula at the beginning. So that concludes the troubleshooting portion of the lesson. We hope this um, lesson on hyperangulated laryngoscopy has been helpful, and we hope you enjoyed the virtual reality format.